Hi, I'm Dr. Christopher Bunick, Associate Professor of Dermatology at the Yale School of Medicine and Editor-in-Chief of Dermatology Times. Today in dermatology, we've had some breaking news, some top-line positive results from the phase 3 clinical trial looking at an mRNA-based vaccine for melanoma. But to break down what all that means is a melanoma expert and researcher from the Yale School of Medicine and a colleague of mine, Dr. Goran Mićević. Dr. Mićević, can you introduce yourself for our audience?
Absolutely. Hello, everyone. My name is Goran Mićević. I'm an assistant professor of dermatology and pathology at Yale University, and also part of the Center for Molecular and Cellular Oncology. Thank you for having me, Dr. Bunick. It's really exciting data that we're witnessing today, which is a result of several years, really, of developing this new platform for individualized neoantigen therapy. So the phase 3 results that we've seen today basically suggests that combining immune checkpoint blockade, which is the standard of care for advanced melanoma, is superior to immune checkpoint blockade therapy alone when combined with this individualized vaccine or neoantigen therapy. So very exciting data for our patients, their families, but also a lot of new research questions and things that we can investigate.
So let's break down a little bit of what you just said. Can you just tell our audience what is neoantigen and what does that mean in the treatment of melanoma?
Right. So neoantigen is basically a novel mutation that occurs in a tumor. It can be a result of a point mutation. It can also be a result of a frame shift or exon or intron splice site. But basically, it is a genetic change in the tumor that's unique to the tumor. It's not located in the somatic cells, and it results in producing a different peptide, potentially presenting it to the immune system. And some neoantigens can elicit an immune response. And in the case of the trial that we're witnessing today, this whole new vaccine approach capitalizes on identifying neoantigens that are specific to a patient's tumor, basically collecting the tumor from the biopsy, collecting blood, performing high resolution sequencing and identifying neoantigens and trying to identify those that will elicit an anti-tumor immune response, creating a vaccine, an mRNA-based vaccine that's unique to that one patient, so very individualized, and then delivering it intramuscularly.
So what you said about individualizing an individualized treatment for a patient really represents a new advancement in personalized care, particularly of melanoma patients, because this is using mRNA technology to personalize the targeting or neoantigens to develop and stimulate the patient's own immune response against this particular melanoma with all of its molecular signature. Is that accurate?
That's exactly right, Chris. I think this is a pivotal trial, first of its kind, where a completely individualized neoantigen is being used in the therapy of a patient. And I think it will open up the door not just for melanoma, but for the broader applicability of this platform in cancer. We've certainly also seen trials with individual neoantigen therapies in pancreatic cancer. There are trials now in bladder and lung cancer. But this is the first phase 3 large study that showed a clinically significant and durable, a meaningful response that I think we'll shortly probably see in clinic.
So let's talk about those responses, Dr. Mićević. That is the primary endpoint of the trial, the phase 3 trial, is recurrence-free survival. And I think the secondary endpoint is distant metastasis-free survival. What do those endpoints mean to you, and what should our audience understand about these endpoints and what the trial data is actually showing?
Yes, so this trial data is actually showing a very significant improvement in both of those endpoints, specifically for the progression-free survival. There's a prolongation. The hazard ratio or the risk of progression is decreased by about 50%. And this is in line with the phase 2b trial data that's been presented earlier at ASCO. And for the distance metastasis-free survival, there's an even greater decrease in the risk to about hazard ratio of 0.3. Which basically what it means for patients and for families is more time to have planning for therapies and also more quality of life. Disease-free survival is very meaningful clinically. It means time that you're not spending in the hospital, times that you're spending outside with your family, and enjoying life, pursuing things that matter to you. So I think disease-free survival will be followed by overall survival. Looking at all the indicators, the curves seem to continue to separate. So I wouldn't be surprised that we see follow-up data that's equally promising.
So it sounds like there may be a real difference in overall survival. Clearly, as you said, with the disease, distant metastasis-free and overall disease-free survival. The question, it sounds to me then that this is not necessarily a perfect cure and you can forget about your melanoma. It sounds like this is a new era where we as the dermatologist will have to think about this therapy, but it's not going to be the only thing we have to still worry about with our melanoma patients. Can you comment on that?
I think it's a really valuable addition and definitely a new chapter, I would say, in melanoma therapy and cancer therapy altogether. How it will fit into the current treatment paradigm still remains to be seen. A lot of the movement that we've seen in melanoma is neoadjuvant therapies, treatments before surgery. The current lead time to develop a personalized vaccine is around 6 to 8 weeks. That's usually longer than required for the time frame to deliver usually checkpoint blockade before people go on to surgery. So it'll be further optimized probably to see how this fits into the workflow. But definitely one thing that I see this being applied to is in the adjuvant setting. For, let's say, folks who receive immune checkpoint blockade and are non-responders, could be candidates for this combined therapy, which has been shown to be superior. But eventually, I think it also might become the default adjuvant setting.
Okay. When we think about what are the patients that are candidates in the future for this mRNA-based therapy, it turns out in the trial that the patients that were enrolled had completely resected melanoma. So this is not going to eliminate the need for surgical approaches. Is that true?
That's exactly right. So the population for the trial was stage 2B through stage 4 resectable melanoma. As you point out, significant number of patients, Chris, have unresectable melanoma, advanced melanoma, for which the standard of care is still immune checkpoint blockade. The trial has not been done yet, but I believe is in progress in unresectable melanoma of the combination therapy. So what's really exciting about this trial, I think the clinical correlates, they found that it's HLA independent. Which speaks to the broad potential applicability of this. It does not necessitate a specific HLA allele in a patient, which means that it potentially could be a very broad treatment for many melanoma patients, not just with a specific HLA type. And again, typing is important during antigen presentation because the peptides, the neoantigens that are being delivered with the vaccine are presented along with HLA molecule. But it turns out that this effect, we think so far, based on the data that's out there, is independent of tumor mutational burden, independent of PD-L1 expression, which is currently being used immunohistochemically to gain an understanding of whether someone is likely or not likely to respond. And it's independent of HLA, which is really exciting.
Well, Dr. Mićević, thank you so much for all of this amazing insights into melanoma and this new mRNA-based therapy. Do you have any final comments, anything we haven't talked about? Do you really want our colleagues in dermatology to know about this particular mRNA-based therapy for melanoma?
Well, I think this is just the beginning, Chris. I think this will continue to be optimized every step of this process, including the discovery of the neoantigens, predicting which neoantigen really will result in a significant immunotherapy response, developing an assay and a biomarker that could tell us which neoantigens are passengers and which are actionable. But I think I'd advise colleagues to keep an eye on this field. It's rapidly developing, and I think this is just the beginning of optimizing this. And I feel that it will be applied to many other cancers beyond melanoma, and we're seeing definitely evidence in that in pancreatic, bladder, lung, potentially other cutaneous malignancies as well.
Well, again, thank you so much, Dr. Goran Mićević from the Yale School of Medicine, joining me, Christopher Bunick, Editor-in-Chief of Dermatology Times, on this exciting day in dermatology with breaking news in melanoma. Thank you.